Good morning, everyone, and thank you for joining us today. I am Colette Chichester. I'm the Vice President of Government Affairs for Care First. I cover the DC and Virginia portfolio for us, and I'd like to welcome you to our discussion and dialogue about the Affordable Care Act today. Today, we're going to be exploring topics of the monumental impact that ACA has had on the insurance industry writ large, and exploring solutions that we as a country are going to have to wrestle with as we consider adopting these types of solutions so that we can ensure that the health insurance marketplace is affordable for generations to come. For a little bit of context before we delve into our conversation, I think most folks know that since 2014, millions of Americans have gained access to comprehensive health coverage through healthcare.gov and many of our state-based exchanges. Not only have more Americans gained insurance, but they've also gained access to better insurance as quality health plans have increased and new insurers have entered the marketplace, as well as the numerous protections that have been put into place because of the ACA. Even though the ACA has actually reduced the number of uninsured members and Americans to historically low levels across our country, what we're finding, and I think many of you will note, is that the cost of coverage continues to be impractical for many of us. In the past year, so last year, the American Rescue Plan Act, or the ARPA, temporarily improved coverage affordability for many Americans by expanding eligibility to ACA premium assistance. However, as we know, those financial assistances are going to expire at the end of the year. And so with that possibility looming and that extension being uncertain, millions of Americans can potentially see their premiums become unaffordable suddenly. So we also know that the implementation of state-based reinsurance programs have been successful for many and helping to ensure the stability of the individual marketplace. But we also know that rate adjustments are continuing and naturally will continue to reflect the increasing cost of healthcare, and that continues to rise year over year. And so with that backdrop and kind of context setting, I'd like to introduce our moderator for today's session. David Schwartz is our interim Executive Vice President for Public Policy and Government Affairs at Care First. And he has over 20 years of experience in health policy, 10 of which have been spent on the Hill, and he was instrumental in terms of helping to craft the ACA. And so with that, I'm going to kick it over to you, David.
Thank you, Colette. I appreciate that introduction. I know that you have other engagements so that you can't stay with us, but appreciate you making time to join us this morning. And welcome to everyone else who has joined us. Happy to have you here. I think we're going to have a great discussion. Before I introduce our panelists, just a couple of remarks. Controlling healthcare costs is certainly not an easy task. If it were, folks would have figured it out long ago, and we would not need to have this discussion today, but obviously more remains to be done. There isn't a single solution that will, magically come along and make coverage affordable for everyone. But there's a lot of evidence out there that suggests the transition to value-based payments from a fee-for-service model is certainly a part of the solution, not only because value-based payment models reduce the cost of care, but they also are known to help reduce health disparities, facilitate a whole person approach to care that improves health outcomes and quality and the patient experience, and they also help promote health equity. And despite the growing body of evidence to support value-based models, adoption of these models has been slow and uneven across the country. Similarly, although the Centers for Medicare and Medicaid Services, or CMS, projects the spending growth for retail prescription drugs to increase over the next decade at an average of 5%, movement to enact legislation to curb the costs of prescription drugs has not progressed with much steam, and so we continue to face those costs. Today, we're fortunate to have 4 panelists here with us that have expertise and perspectives required for us to dive in and discuss The success of the ACA to date, which is important to celebrate, but also solutions that would help bolster everyone's ability to facilitate more affordable coverage in the future. Our first panelist is Mila Kaufman, who is the Executive Director of the DC Health Benefit Exchange Authority, which was established by the District of Columbia to develop and operate the ACA online health insurance marketplace, which is called DC HealthLink, for residents and small businesses, excuse me, here in the district. Approximately 100,000 people have private health insurance through the DC HealthLink, and this includes more than 5,000 district small businesses, approximately 11,000 congressional staffers and members of Congress, and thousands of district residents. Mila successfully built the organization that now has over 100 employees, an annual budget that exceeds $30 million, and she has led policy initiatives and secured passage of legislation with unanimous support. Our second panelist is Michelle Eberly, who is the Executive Director of the Maryland Health Benefit Exchange. The MHBE is responsible for the administration of the Maryland Health Connection, which is the state's health insurance marketplace. Over 180,000 Marylanders are enrolled in coverage through the Maryland Health Connection, with enrollment up 9% in just the last year. Michelle began her tenure with the state of Maryland in May of 2013 when she was hired as the Executive Director for the Maryland Health Insurance Plan, which was the state's high-risk pool. She then served as Director of Plan and Partner Management and Chief Operating Officer for the Maryland Health Benefit Exchange before being named the Executive Director in December of 2017. Our third panelist is Eva Dugoff, who is a Senior Health Advisor for the United States Senate Committee on Finance. Eva joined the committee from Berkeley Research Group, where she was Associate Director, and the University of Maryland School of Public Health. Eva has published more than 40 peer-reviewed papers in academic journals, including Health Affairs and the New England Journal of Medicine. She received her doctorate from the Johns Hopkins, Bloomberg School of Public Health, and her master's degree from the George Washington University. And last but certainly not least, we have Corey Insulin, who is a Senior Health Policy Advisor for the United States Senate Committee on Health, Education, Labor, and Pensions, or HELP, as it's known. Corey started his congressional staff career in the House of Representatives, but he now serves in the Senate, again, on the HELP Committee. Corey received his Bachelor of Business Administration from Shenandoah University. I'd like to welcome all of our panelists, and before we start with questions, I would just like to note that in the interest of candor and appreciation for the fact that we have individuals who work for elected officials on our panel today, their comments are not for attribution to them. They're members of Congress or the committees for which they work. So appreciate everyone respecting that so we can have a robust discussion. So I'll kick off with the first question. As Colette mentioned at the top, the ACA has certainly had an extensive impact on how Americans obtain healthcare coverage. From each of your perspectives, what are some of the most significant ways that the ACA has changed the insurance landscape over the past 10 years? And Mila, since you've been at the DC Health Benefit Exchange from the very beginning as its first employee, maybe we can start with you.
Yes, thank you, David. And I'd like to just start by thanking Care First, Blue Cross Blue Shield, for celebrating the last 10 years of the Affordable Care Act, and your leadership in the region for adopting and working with us as a great partner to make sure that the state-based marketplace is successful. Let's see. We are the state-based marketplace in the District of Columbia, and we were one of 4 state-based marketplaces in 2013 to open for business on time on October 1st and stay open. And since we've opened, we've helped to cut the uninsured rate in half. And so now more than 96% of the District of Columbia residents have health coverage. Now, that is really a reflection of our mayors and our policymakers being early adopters of the Affordable Care Act. We expanded Medicaid coverage. We enacted all of the market reforms that the ACA had. And we made sure to leverage the standards, the federal standards, and build on them. Now, of course, the Affordable Care Act has lowered premiums for millions of Americans and established high standards. So health insurance actually works when you're sick, not just when you're healthy. And before the ACA, if you were around, and many of us were, the private health insurance market really didn't work. You had to be in almost perfect health to get private individual health insurance. And if you had any kind of medical need, you were either rejected because of medical underwriting, or you were surcharged, or your existing medical condition, your pre-existing condition wasn't covered. The Affordable Care Act changed all of that and gave not only DC residents, but millions of Americans access to financial security as well as health security. And I just want to conclude by sharing a story of what happened before the Affordable Care Act. A young woman in her 20s who I met, whose baby was sick, shared this with me. When her baby was sick, she called an ambulance. The ambulance showed up and asked her if she had health insurance. And at that time, she was uninsured. Well, the ambulance took her baby to the hospital, but wouldn't allow her to ride in the ambulance because the mom was uninsured. Unfortunately, on the way to the hospital, her baby died. And she wasn't allowed to be there when the baby took her last breaths. So imagine the indignity and the suffering that being uninsured causes. And the Affordable Care Act has made tremendous improvements and covered millions of Americans with affordable quality health insurance.
Thanks, Mila. And that story is certainly resonates. Michelle or Eva or Corey, welcome your thoughts.
I can add from Marilyn's perspective, and David, thank you again for having us here to provide these experiences we've seen, or we've had, and we've seen in our state. So obviously, as Mila talked about, the biggest change in the landscape was eliminating the pre-existing coverage, which was, Mila talked about the medical underwriting. That was a game changer. I mean, that really allowed many more people to get and use healthcare. What we have seen in Maryland is a significant impact to our uncompensated care. So previously, people that didn't have health coverage would go to the emergency room or get care where they could find care. And the rest of the citizenry was paying for that health care because it would be in our uncompensated care that we all would pay for through our insurance premiums or other taxes. So that was significant that it reduced that uncompensated care for all. And I always like to talk about health coverage pre-ACA and post-ACA. Pre-ACA, it really was intended to be a health or an insurance policy to help prevent you from going into bankruptcy. I mean, that's what we always talked about. You don't want to have a major health incident that will put you into bankruptcy. Post-ACA, we've shifted how we talk about it, and it really is health coverage. You have wellness benefits, you have pre-deductible services. There's a lot of other items that now, even at a baseline, you're getting health benefits. It's not just for to keep you out of bankruptcy if you have a catastrophic condition. And then the other change we've seen in the landscape is just see a number of self-employed individuals and folks that maybe want to be leaving a primary career and moving, they're in their 50s, they want to move into a secondary career, but are worried about health insurance, having an option to purchase health insurance and an affordable option. So it's giving entrepreneurs and older folks that may want to start on a different path more options and knowing that they will have health coverage.
Great, thanks, Michelle. Eva or Corey, either of you want to chime in?
I'll jump in here just to add a couple of points. But first, I also want to add my thanks for inviting me to be on the panel, and just to repeat what David mentioned. My remarks represent my views and not those of Senator Wyden or the Senate Finance Committee, and should not be attributed to the senator or the committee. So I would just add two pieces. One is to underline what Michelle just said, which is that the ACA made significant changes to the individual market, and it's not as scary as it used to be, and which allows people to pursue their dream job instead of being locked in a job that they may not want just because it has benefits. So that's one. And the second I would point to is just the broader impact of the ACA with respect to accelerating federal adoption to move away from fee-for-service based reimbursement to value-based payment, and really accelerated those efforts in the Medicare program, which has been a leader in this space. And we've learned a lot from those efforts and look forward to talking about those later. Thank you.
Great, thanks, Eva. Corey?
Sure. I would echo Eva's thanks to Care First for inviting me to participate, as well as the disclaimer that remarks are obviously not attributable to Senator Burr, the Health Committee. I guess I would just add, in addition to all of the valid points that have been made, that the ACA did change and to some degree adulterate, I think, the way we think about coverage in relation to the other things that make up a high quality healthcare system. I think for political reasons, it's probably been placed at a higher level because it's candidly a lot easier to talk about as well as to effectuate, right? Medicaid expansion, for example, if we were creating a program out of scratch, it would be politically intolerable to subsidize able-bodied working age adults at 90 cents on the dollar, whereas seniors, the disabled, and children would get 60 cents on the dollar. And in the individual market, I think we also have to remember that coverage is not necessarily the panacea. For example, for individuals who don't receive cost sharing reductions, the average deductible for a silver plan in 2021 was $4,800. Someone making 251% of poverty, roughly $32,000 a year, for a deductible of almost $5,000, it does make one question the utility of that coverage. And I would think moving forward, we need to continue to have conversations about increasing the quality of coverage, addressing the actual cost of healthcare, and seeing how we can leverage the existing resources to give individuals more control over how their healthcare dollars are spent.
So thanks, Corey. That's actually the perfect transition to the next question, to focus a little bit on affordability. So individuals and families in Maryland, and certainly in other states across the country, have benefited from state-based reinsurance programs, which reduce premiums for many consumers. Based on your experience, how important is the role of reinsurance programs and other actions that states have taken or can take to improve affordability in the ACA markets? And since I mentioned Maryland, it seems like we should start with you, Michelle.
Thank you. Maryland was one of the early adopters of a reinsurance program. I think there have been 3 other states at the time we looked at it. And we actually took advantage of the federal government pausing the health insurance fee, which was a 2.75% fee in 2019. And I believe it was 2019. And we said, well, if that fee, which the carriers had already baked into their rates, was going to be paused, let's look at using that to start a reinsurance program. And fortunately, and again, Care First was at the table, and our issuers were all at the table, and our legislature was there and really helped move it forward And I can't say enough about CMS and how great they were and Societal really helping us get our waiver through fast. What it's allowed us to do is over a 3-year period, it really allowed us to reduce our premium rates over 32%. And that's each year. It was double digits each year. When we moved into the 4th year, last year, we saw a 2% increase, a little over 2% average increase in our rates, which we knew that it would start to balance itself out. And we'll say where things are headed now to a later discussion. But it really has had a significant impact on the cost of premiums. Now, what that has done, obviously, is allowed more people to purchase health insurance. Direct correlation with lowering the price of the health insurance premium and the number of people that are purchasing health coverage. We've had each year significant growth, and we're at our highest level ever this year of over 180,000 folks that have purchased health insurance. It also has allowed increased purchasing power by consumers. So as their health insurance premiums went down, what we saw, and we really didn't expect this or plan for it, the purchase of standalone dental plans went up. So folks thought, well, I have a little more money in my pocket. I can now get dental coverage. And these were some folks that have Medicaid, some folks that work for an employer, but the employer doesn't offer health or dental insurance. So it really helped our state as a whole. And we also saw people buying up in terms of the richness of their benefit plan. So they may have been in a silver benefit plan, which was about 70% that would be covered by the carrier. They bought up to 80% plan. And that has just really helped people get more coverage with less out-of-pocket costs. It also demonstrated more purchasing power in rural areas and also for young adults. And that's been a huge one for us, our young adults. Not only did it allow more 18 to 34-year-olds to come in, but it also allowed Maryland to set aside some funds to do a subsidy specifically for young adults. And that averaged about $40 per month for our 18 to 34-year-olds. What we saw this past year, which was the first year of that program, we brought in an additional 10,000 young adults. Now, what that does to the marketplace overall is that you have younger, presumably healthier people. It lowers the morbidity rate for the pool as a whole, which helps drive down those premiums. And it made our marketplace more attractive. Insurers that were looking at us and knew that some of those very high risk claims would be covered through a reinsurance program, they took a second look about coming back into the marketplace. So the reinsurance program for Maryland has just really been a game changer for us and allowed us to increase enrollments and provide affordable health coverage.
That's great. Before I ask others to chime in, just want to remind folks, you can submit your questions and answers using the Q&A function on your Zoom screen. We'll try to get to them with our panelists. If we sort of run out of time, we will be happy to follow up with folks offline, but please do make use of that feature if you have a question. Mila, it looks like you've got something to add here. Please go ahead.
Thanks so much. And I'd like to congratulate Michelle for their reinsurance program. It's quite important in making premiums more affordable. I just want to focus on what we've done and other states have done as well to make access to care more affordable. We know that with bronze plans, especially, the deductibles are too high for many people to actually access care. So in the District of Columbia, we have standard plans in addition to non-standard plans. And for our standard plans, essentially, we have access to medical care without deductibles for certain essential benefits, including you can go to your primary care physician as many visits as you need without a deductible. You can access specialists, including mental health and behavioral health and substance abuse outpatient specialists without a deductible. Urgent care, no deductible. Generic prescription drugs, no deductible. And so that benefit design is critical in helping us to ensure that residents with deductibles they can't afford can access essential medical care.
Thanks, Mila. I'm actually going to transition to the third question, which actually relates to one of the questions that was submitted from the audience. It's about enrollment. So marketplace enrollment is up just over 20% in 2022 with a record high 14.5 million people enrolled in ACA plans. As discussed earlier, this is largely due to the impact of the American Rescue Plan Act, which enhanced the financial assistance for premiums. In January, the Biden administration announced that healthcare.gov consumers saw their average monthly premium fall by 23% compared to the 2021 enrollment period, which was before ARPA was enacted into law. So with the ARPA premium assistance enhancements set to expire at the end of this December and the possibility of an extension uncertain, I'd like to hear from all of you sort of what we think the impact of a lapse would be, and also to capture the question from the audience, how much of that enrollment do we think is attributable to the Great Resignation? So maybe we can start with you, Mila, and then hear from the rest of the panel.
Sure. So the American Rescue Plan lowered health insurance premiums for middle-class families across the nation and in the District of Columbia. And we would like Congress to act to not let this middle class tax break expire at the end of this year. So for us, what we're seeing right now is record inflation, just like everywhere else. The recovery from the pandemic having huge economic implications, Putin's war, gas prices, and right now there are just significant pressures on all families, and especially middle-class families. And so to take away this tax cut at the end of this year is going to be unsustainable. We're going to see record losses in health insurance coverage. And let me just underscore something Michelle said earlier. For us, our individual marketplace is mostly sole proprietors. These are entrepreneurs who left large employers, sometimes government, to start up their own practice in whatever they choose to do. They don't have any employees, so they rely on affordable, stable, private health insurance marketplace. We have some who work for employers that don't offer job-based coverage for anyone or for part-time workers, for example. So those are the residents that also rely on affordable health insurance. And because of the American Rescue Plan lowering premiums, our residents save on average $460 a month in premiums. And that's a big deal. If that goes away next year, we're looking at about $5,600 in more premium on top of the premium changes and increases that occur every year because of medical inflation and other reasons. So for us, letting this tax break for the middle class expire will cause thousands of residents to become uninsured. And we know millions across the nation will become uninsured.
Thanks, Mila. Michelle, I hope it doesn't bother you, but I'm going to skip over you because the temptation is far too great with two Senate staffers on the panel to ask them, unfairly what your crystal ball projects for the ARPA enhancements to the tax credits. And I think we started with Eva last time, so Corey, maybe we'll start with you.
Sure. I guess I don't have a crystal ball per se, but can offer a few thoughts just sort of on where we are with the policy and maybe where we go. So when it was originally passed, right, this, as along with all the other spending in the American Rescue Plan, was justified as an acute response to the COVID-19 emergency. I think while we continue to grapple with the pandemic and that's ever changing, the emergency has, and the justification for continuing this massive amount of spending has probably expired, right? If we have dropped the Title 42 requirements, if the CDC is saying you no longer need to test or re-enter, and any number of other indicators that the administration believes we are putting this behind us, I think we need to have a conversation about what is the off-ramp to normalization. And if the goal is to continue to stabilize and bolster markets, that's absolutely fine. I am not convinced that this is the best way to do so. Under CBO's current baseline, we're already going to spend $807 billion on premium tax credits over the next decade. If we were to continue the subsidies as enacted over the next decade, you'd be talking about well over an additional 200 billion. And if the goal is to increase coverage, I think what we've seen and what CBO has projected is it's a relatively inefficient way to do so, right? CBO's original estimate found 75% of the spending went to individuals who already had and would otherwise have insurance. So it ended up coming out to like $17,000 spent for every new person insured. And a lot of the way that that benefit is distributed is candidly regressive, right? Those at the lowest end of the income scheme were already getting significant subsidies and see a small marginal bump up under this policy, whereas individuals of significant means in some cases, 700, 800 times poverty, are receiving premium subsidies, oftentimes because it's linked to a percentage of income that are in excess of the benefit that those of modest means are getting. And generally speaking, I think when we're talking about spending such large amounts of money, I think targeting them in a more progressive manner is something Congress has traditionally tried to do. And I also think it failed on the middle class tax benefit. I would also note that while I'm not unsympathetic to that, DC and Maryland do have the two highest median incomes in the country. And I think when we're talking about targeting these policies towards lower income folks like those in North Carolina, for example, we need to continue to get at what are the fundamental problems that has caused the ACA to fully deliver on what we all thought it was going to be. In April of 2014, CBO projected 25 million would be enrolled in 2022. Today, with these expanded subsidies that were far greater than ever contemplated by the ACA, we're at 14.5 million. So clearly there's more work to be done that just shoveling more money into premium subsidies cannot solve. Now that said, not unsympathetic, again, to taking action to bolster the markets and improve both the quality and cost of coverage, right? Some ways you could do that. You could build off of the Trump administration's HRA rule and continue to explore ways to give individuals control over healthcare resources, particularly when, you know, for an example, if an employer wants to give an individual a subsidy, like through the HRA rule, to go onto the exchanges, you have that virtuous cycle of bolstering the exchanges and lowering premiums across the board. I think that's a great place to start and something we should look at building off of. I also think we should work to fix the fundamental inequities in the system. CBO recently said that those aged 60 to 65, so those not quite ready to get on Medicare yet, but as a population, again, if we're talking about on average, should have the highest healthcare costs by virtue of their relatively more advanced age than everyone else. They are not getting the full benefit of their premium payments. So in other words, they spend more on premiums plus premium subsidies than they get in benefits. In a community rated market where premiums are set to cover everyone, those who on average should have the highest healthcare costs, it should be the other way around, right? They should be getting more out of the benefit than they are putting in. To me, that is an indictment of the market structure. And again, builds the case as to why we need to think through how to make a more rational system that makes sense for everyone, while continuing, again, the important reforms the ACA made to include protections for pre-existing conditions and bolster the individual market.
Thanks, Corey. Eva.
Thanks, Corey. I think there's a lot that we can discuss in the future. I think just a couple of points that I would add was that with respect to the ARPA tax credits, I think that we've seen that it's bolstered the insurance marketplaces and stabilized those markets and lowered premiums overall, particularly given what we're seeing on inflation. I think that now is not the time to raise premiums for working families, and think that including an extension of these subsidies will be really important for 2023 and forward. This is something that's very important to the Democratic caucus and particularly the chairman. And so hopefully more on that front in the days ahead. One point, just to go back to the discussion on affordability, I would be remiss not to mention that Senator Wyden, when he was a down-diced member of the Senate Finance Committee, worked on the 1332 waivers, which provide states the opportunity to experiment with other ways of structuring coverage and the premiums, such as the reinsurance programs to achieve universal coverage and affordable premiums for all in the individual market. I think that there's some interesting state innovation in this space, particularly looking at Colorado and Nevada. And as long as states are meeting the 4 key guardrails of the 1332 waiver, we look forward to seeing these programs move forward and other experiments so that we can find the best ways to achieve affordable coverage across the board.
Thank you, Eva. I appreciate all those comments. I'd like to shift a little bit to circle back to something I mentioned earlier, and that is value-based care. I think throughout this conversation, a number of us have raised it. Fair to say that we, I think, agree that there is a lot of promise in the role of value-based care arrangements, helping to reduce the cost of care, so helping improve affordability, as well as addressing health equity and improving health outcomes. Would really like to hear what your thoughts are on how we accelerate the transition to value-based care, so that we can hold providers and payers accountable for health outcomes and incentivize efficient patient-centric care, both within the Medicare program, which I think Eva mentioned before, but also much bigger picture across the system. And maybe, Corey, we can start with you for this one.
Sure. From the Health Committee perspective, we have jurisdiction over ERISA, so we're governing large self-insured employers. And from where I sit, I sort of view them as having the greatest ability to innovate through their payment systems, given the amount of leverage they have relative to other payers to do so, and general private sector ingenuity. And many of them are extremely interested in doing this and taking active steps. And I think Congress should support them where possible, and definitely take care not to undermine those efforts with any policies that will either weaken the risk pool and therefore market structure and leverage they have over providers in those negotiations. I also think we should entitle small employers to that same sort of market leverage by allowing them to pull together through association health plans, which will, again, have the virtuous impact of increase or reducing premiums for those individuals while giving them greater ability to negotiate with providers and transition to more value-based systems that are potentially advantageous to the payer and patient. And I also think we need to have a conversation about the extent to which some well-intentioned government policies may be actively inhibiting the proliferation of value-based arrangements. I think, for example, the Medicaid best price rules that actively discourage discounts in the commercial market are just like the perfect example of this. So I think as everyone knows, as of right now, Medicaid is statutorily required to get the best price of any payer in the country. This is, again, extremely well-intentioned, but what it has the effect of doing is discouraging discounts in the commercial market. So as of right now, we have life-changing innovations in precision medicine, gene therapies that cure blindness. Eventually, we're going to have, some sort of potential cure for diseases like sickle cell. And we're going to have to grapple with how we pay for these because they're going to be extremely expensive. And again, they will be life-changing. And one of the ways that I think large employers and private payers are looking at doing this are through value-based arrangements, right? Pay over time if you continue to see the clinical benefit from that treatment. So it's not necessarily $2 million, for example, upfront for something that, might work 75% of the time. And right now, what we've seen inhibiting that is the Medicaid best price rule, where if you have one of these life-changing treatments that maybe does not work in one patient, and therefore the cost is negligible, now every payment for a Medicaid beneficiary in the country is now negligible, and then you've destroyed any incentive to invest in that sort of medicine or disease state. And I think that's an area where folks can come together in a bipartisan manner to increase the proliferation of VBAs.
Eva, we'll let you present the Democratic perspective, then we'll turn to Michelle and Mila.
Thanks so much. I think we see things a little differently on this side. I think I'll focus on actually someplace where Corey started our previous conversation, which is the patient. I think that one of the things that we've seen with the ACA is an explosion of value-based payment levers driven by payers, Medicare and private players. And this has been particularly powerful when Medicare and private players have come together, such as the Maryland total cost of care model. And so really to tip our hats to that as a model for how we can think about population level payments. One of the things that was included in the ACA but has not been implemented was section 3506, which was a Wyden-Gregg bill that would have focused on shared decision-making models and providing an avenue for engaging patients when their care choices are, it's unclear which care choice would be best. So for example, surgery or physical therapy. And I think that we've really lost an opportunity to engage patients with respect to what is value-based care. I think that payers know, though are not necessarily clear on how to do it best in all scenarios. But patients are really haven't been a focus of this discussion. And I think that there's more that we could do in collaboration with researchers who have been active in this space on how to educate consumers when there is choice. Because when there is, they often choose the less expensive option, the less invasive option. So it's one of the things, going back to your original question, David, I would suggest that we should think about for the next phase of value-based care.
Yeah, thank you for that. Michelle?
I will just add that we are fortunate in Maryland that we do have the Medicare waiver, which has a total cost of care model. It has global budgeting for our hospitals. And that really helps us as a state bring all stakeholders together to focus on the care delivery system and the cost of care. One of the programs that has recently been stood up is our Maryland Primary Care program. And that's working with our providers, our physicians, to really engage at that very basic level of primary care, of looking at, having the patient-centric view of looking at treatment and staying engaged and keeping that patient engaged to assess their own treatment and make those decisions and help guide them. And that's been, from the provider standpoint and from the state standpoint, a very, very good program and very successful. and from a consumer standpoint as well. And I can attest to that, having been a consumer. The other item is how we do it at the exchange. One way that we can help influence is looking at our plan certification design. So we have not standard plans, we call them value plans actually in Maryland. And whenever we're looking at those benefit structures, we're looking at what are those cost drivers in the state and how can we partner with other agencies and looking at what are the public health initiatives. So for instance, looking at diabetes as one of our top cost drivers in the state of Maryland. So what can we do with our carriers? And it's been a partnership of talking to them about how do we provide insulin and glucometers and test strips, things pre-deductible, low cost, so that we're looking at shifting that needle on cost and care at a global basis based on state priorities. So those are just some of the items that we've looked at in Maryland to date. And of course, it is such a big issue. If we're not controlling our costs, we know we can't afford health insurance.
Mila?
Sure, just quickly. Well, first, congratulations to Care First, Blue Cross Blue Shield, for being a leader in the region on value-based payments and launching one of the most successful pilots there is in the region. When I first came in, it was amazing to see what you were doing, and then the academic articles about your effort, which I encourage others to look at in one approach on value-based care. But I would just add, from the state-based marketplace perspective, one of the things we are focusing on is looking at covered benefits. So low value benefits and zero value benefits where the treatment can actually hurt the patient. So we're looking at that and either getting rid of agreed upon zero value and low value benefits altogether, or changing the cost sharing to put essentially more of the cost shift on those benefits to discourage patients from seeking care that could actually hurt them.
That's great. So I know we don't have a lot of time left. I'd like to pick up on something that emerged from Corey's remarks, and it's the high cost of drugs, right? So the example that Corey gave, it was pretty extreme at $2 million a treatment, but it is a real example. But I think we know that the cost of drugs, continues to increase, certainly for us at Care First. The prescription drug benefits that we provide both on the medical side as well as on the pharmacy side represent an ever increasing proportion of the total amount in claims that we pay out, and that has been true over the past several years, and it's a pretty steep uptick. We know that Congress had considered, and part of Congress had passed some legislation aimed at trying to rein in drug prices. So far, all eyes on the Senate, and so far there's not been much to see in terms of the legislation actually moving, understanding there are a million political reasons why, but sort of curious about what do we do? And Corey, I took your point well about the connection between the price and other policies, particularly in the Medicaid space, that manufacturers pay close attention to in terms of the larger impact. But if we start with that price being the issue, what do we think, if anything, can be done about that? And Corey, since you started last time, I'll start with Eva this time.
Thanks, David. So I think, well, first things first, I should note that I don't primarily work on prescription drugs. I primarily work on other parts of the private insurance market for the Senate Finance Committee. that said, prescription drugs has been the hot topic since I've been on the Hill and well before. This is something that is very important to the Democratic caucus, and there's wide support for policies that were passed by the House in the Build Back Better Act around an out-of-pocket cap in Part D and allowing Medicare to negotiate drug prices. I think broadly, from where I sit, we think that there are three big problems in the prescription drug space. The first and foremost is that prescription drug prices are just too high. The supply chain profits as prices go up, and so competition doesn't actually work. And so we need to make competition work. The second problem is that there are monopolies in this market, and the monopolies lead to higher prices. And that's why we need Medicare to negotiate and to be at the table. The third problem is that patients are suffering and paying too much at the pharmacy counter. And that's one of the reasons why an out-of-pocket cap and Medicare Part D is really so important. So those are three pieces there.
Thanks, Eva. Corey?
Sure, and I appreciate the recognition of, while I did use the example of one particular type of therapy, I would also note that we pay too much for all healthcare, right? Relative to other nations, we actually pay less as a percentage of healthcare on prescription drugs than nations, including those that do negotiate the price of drugs, like Germany, Canada, and Japan, right? We pay about 8.4% of all health expenditures in this country on prescription drugs, which is actually down from 10.5% in 2006. Whereas on hospitals, we're looking at about 30% and physician services about 20%. What's the right percent? I don't know. But I do worry about what massive government intervention in the market particularly means for things like innovation, right? We have one study, for example, out of the University of Chicago that found these broad-based price controls would result in 135 less new drugs through 2039. And, we have serious concerns with what that would mean for patient health in the long term. I think competition does work, right? We do hail Part D as this sort of panacea of competition. And in Part D, we have, among non-low income subsidy beneficiaries, we have a generic dispensing rate of 92%, which is good. And that's not to mean that there aren't areas to improve, but we do see that generic competition does bring about competition, or does bring about price reductions. That's actually part of the reason we have some of the sort of idiosyncratic issues with rebates that we do, is that there are fiercely competitive manufacturers with each other and offering ever greater rebates to get on formulary. That's not to say things are perfect. And Senator Crapo of the Finance Committee, as well as Senator Burt, did introduce legislation. And I think this is an area where, Eva and I would agree, capping out-of-pocket costs for seniors is a no-brainer. Redesigning Medicare Part D is one of those unicorn type policies that I think would have the virtuous impact of doing that, capping out-of-pocket costs for seniors, but it would also fix the incentives to use high-cost drugs when lower costs exist, while also reducing government's liability in the reinsurance phase of the benefit. And you can do that in a budget neutral manner that keeps premiums harmless while also having all of these great effects for patients and the Medicare program.
Thanks, Corey. Michelle?
Well, I'll just add that obviously we all know the impact this has to premiums. I'm very grateful to our Maryland legislature who put a prescription drug affordability board together. Very excited to see what will come out of that. And absent anything coming out at the federal level, I think as states, we're going to have to look at what we can do to contain costs, and whether it's through the Prescription Drug Affordability Board, whether we look at other purchasing structures. But if you look at carving out prescription drugs from a health plan, the health plan costs would significantly decrease. So clearly there is some issue around, what are we paying for our drugs? And I'll just use a personal example. There was a year when I was not working and we didn't have health insurance, and my husband was getting a drug skin cream. We went to refill, it was $100. He went back to his primary care doctor and said, I just can't afford this at $100. thank goodness a primary care doctor was one who was willing to sit with him and look at the drugs. He found another one for $5. But it took a lot of self effort and a nice doctor to sit with us to figure that out. And that's, that just isn't how we should operate in our country.
And Mila, it looks like you'll get the last word.
Well, very quickly, when you look at the rate filings year after year, the cost of prescription drugs is a major factor of where private health insurance rates end up. It's both the price and utilization. And so if Congress can adopt a policy that will help, that will have an endless positive impact on the price of private health insurance coverage, whether it's a large self-funded employer providing coverage or a small business or a sole proprietor getting coverage for herself. It will make a huge difference, and congressional action is necessary. I do not think that states can solve this issue. If states could do it, then we would have examples to point to where a state has successfully either negotiated with pharmaceutical companies or produced their own medicine or have successfully done other interventions. This is a prime example of a policy that needs congressional federal action.
Great, thank you, Mila, and a huge thank you to all four of our panelists. I'm mindful of the time. I think this conversation could go on for hours, if not days, but appreciate all of your thoughts and perspectives. Again, on sort of celebrating some of the successes and achievements, but certainly thinking about what we need to do going forward to address the issues that remain, particularly focused on affordability. So greatly appreciate all of you for joining us and taking time out of your busy days. And a huge thank you to everyone who dialed in. We greatly appreciate your time as well, and hope everyone has a good day. Thank you.